Welcome everyone to our opioid use disorder and pregnancy workshop. We want you to sit back, relax, and learn about this project and everything that we've done in the state of Tennessee. We're moving from wave 1 to wave 2. We will have our Q&A at the end, so please chat any questions, concerns, or feedback that you would like to be discussed. And so here we go. Our agenda today. So we're going to discuss our screening data from wave 1. Terry's going to give us that. Our wave 2 team sharing, including ways to improve communication between our OB and infant teams. Discuss urine drug testing versus expert barriers. We'll speak with Dr. Trisha Wright and Dr. Young, and we'll gain insight on OUD OEN. And then we'll take questions from our audience. And finally, we'll do next steps for our project. Don't forget to chat in, okay? Thank you. This is our progress from wave 1 into wave 2. So our antepartum care, our maternal care, and our infant. First up, we have Terry Scott, who helps us with our TIPQC design, manages and maintains our REDCap databases that we use to support the TIPQC projects. She's also responsible for creating customized reports for our TIPQC QI project and various stakeholders. I'm going to stop sharing now, and Terry, you will have the floor.
Okay, thank you, Bonnie. Actually, would you mind continuing to share? I'm sorry, and I can just tell you when to progress if that's okay.
Definitely.
So hi, everyone. Thank you for joining us. What I wanted to share today is a look back on the screening data that our participating teams captured from May of 2019 to December 2020 in our wave 1 of our project. And really what I wanted to also offer is some insight as to why we chose to focus or continue to focus on screening in wave 2 of our project as well. Can you go to the next slide, please, Bonnie? So let's first just kind of recap on the data capture you did. And for those folks who were not really a participating team, this has to do with a project that we had, the monthly sampling screening, where the participating teams were asked to randomly sample 20 charts of pregnant women who delivered at their facilities and review those charts in a given month. So Bonnie, if you go one more slide. So what this graph actually depicts is the data capture across, in this case, our 12 participating teams. We had a couple more participating teams, but not everyone is able to get off the ground with data capture. And you can see that from May 2019 to December 2020, we had a lot of teams capturing our data. And actually, if you go to the next slide, Bonnie, what you'll see is actually 6 of the 12 teams were actually able to capture sampled and reviewed charts the whole entire project timeframe. So kudos to everyone that captured data, but especially big kudos to the teams that were able to capture data across the whole timeframe. If you go to the next slide, Bonnie, what I wanted to focus on first is really the primary questions. A primary question that we had you answer for each of the charts that you reviewed, and that was substance use disorder screening documented in the woman's prenatal and/or labor and delivery medical record? And that was really the crux of our screening, the first level of question. So if you go to the next slide, Bonnie, what you'll see, this is a run chart, a P chart of the percent of any SUD screening documented in the charts per month across the 12 teams that captured any data. And what you can see is that we had a lot of variability, as we always do, across our participating teams. And if you actually go to the next slide, Bonnie, but what is interesting is when you focus in on the 6 teams that, in my mind, had sufficient data and we're not already screening and documenting all women for SUD, because some of our hospitals were, even prior to the start of our project, what you see is that 5 of the 6 actually saw an increase from baseline. So kudos to that group, really great job. If you go to the next slide, Bonnie, but I will have to say, we saw some variability, we saw some increase, and this graph actually depicts, if we combine those 6 teams, those 6 hospitals that were highlighted on the previous slide, if we combine them in aggregate as if they were one giant participating unit, then you can actually see that we had an increase from about 85% to over 95% across, May of 2019 to December of 2020, which is really great. But we did actually have a decrease at the end, which again, COVID, it impacted all of us. And it's definitely evident in our data. But what I'll have to say is moving into phase 2 or wave 2 of our project, it would be great if as a state, we could actually get back up to that 95% of all women being screened for substance use disorder at some point during the pregnancy, if not really have the goal of every single woman that comes into our care for pregnancy, even if it's not till labor and delivery, that she is screened for substance use disorder. Go to the next slide for me, Bonnie, please. As I said, yes, when these 6 teams are combined, we see an increase from about 85% to 95%, but there is a fall off. The next slide, Bonnie. Then the secondary question, so the primary one was any SUD screening documented? Yes or no? The secondary question was really the crux of one of our bundle items, one of our PBPs, and that has to do with the validated screening, using one of the tools that Dr. Wright was mentioning, like the 5 Ps or the NIPA, whatever like that. So what we're asking in the secondary question is, of those records with substance use disorder screening documented, was the screening using a validated screening tool? And it wasn't just a urine screen, or it wasn't just a, hey, self-report, anything like that. So if you go to the next slide, Bonnie, what's interesting, or what's important to note about this chart, is that the denominator for this P chart, for this percentage, is actually the numerator from the previous. So it's a little bit, it's not out of the original number, it kind of shifts to saying that of those that had documentation of some type of SUD screening in their record, that now goes to the denominator. And then we want to know, of those, how many you were using a validated screening tool. And just like with the previous run charts, when we look across our 12 participating teams that were able to capture any data, we see a lot of variability, but you can definitely see that some had a lot of change over the course of our project. So if you go to the next slide, Bonnie, in particular, of the 8 teams that again had sufficient data and were not already utilizing a validated screening tool, because there were some that were, we see half of the teams, 4 of the 8 really saw an increase from baseline. And you can definitely tell in talking with the teams, with the huddles and things like that, that a lot of them were able to incorporate the validated screening tool into their EMR. So it became very much part of their process, and every single time a woman was screened, it was using that validated screening tool. If you go to the next slide, Bonnie, like before, if we now combine some of the hospitals in aggregate, and in this case, I'm combining the 8 teams that had some amount of data in aggregate, you still see that signal of noise. You still see, now most likely it's those 3 or 4 teams that really saw a huge increase, but we do see, and if you go to the next slide, there we go. We actually see an increase from about 10% using a validated screening tool to over or almost 50%, which really for us starting at such a low percentage at the beginning of our project is huge. And it is definitely something we should celebrate, and we should pat ourselves on the back. But like I said, just with the any screening, are we screening at all? If we can reach that to be 100%, as a team or as a leadership team, we're hoping in phase 2 or wave 2, we can actually go beyond 50%. We feel we can do better. And we internally have set the goal of, by the end of the wave 2 project, which is December of 2021, we would like to see at least 80% of those women who are being screened for SUD at some point during the pregnancy are actually being screened using a validated screening tool. So this is definitely kind of a goal for our participating teams, to really get that validated screening tool as part of their process and used every single time. That's all the data I wanted to share. Dr. Young, I don't know if you want to chime in with any of your thoughts, or Bonnie, or anyone else.
Thanks, Terry. I think it's so good to see all this data, and so good for us to see how combining all the data as an aggregate, what that looks like for a state for our state as a whole. I think that the implementing a screening expert process for not only for inpatient, but for outpatient and across any institution, but large institutions in particular, is a real challenge. And I think for me, harder than I ever even expected. And so kudos to all the teams that really showed those big increases by getting the validated screening tools into their EMR and getting it done universally, or almost universally. It's really good.
I think the teams have done a really good job, and it was difficult at times for some because of COVID. It took some of the data people away from the hospitals. The nursing staff went back to the units and was working. So then there were times they were lagging, but for those who were able to do it at the time, I think they did a phenomenal job making sure that they did what they needed to do. So we appreciate that.
Yeah, and I also
Thank
would
you,
like
Terry.
to say that I think that this is a real, wave 2 is an opportunity to take what we've learned and just really take it to the next step and really, really cement these processes into place so they are just hardwired in and they happen every patient, every time. And for teams who already have it down really well inpatient, well, maybe this is the time to make sure in all your outpatient settings that you are doing a screening at the new OB visits. For some institutions that might be harder because you might have less control with those outpatient clinics, particularly for private practices that may not be employed by the hospital. But I think that there is a lot of opportunity for education and outreach to those partner facilities, especially if they know that it's a quality measure.
Terry. All right, so we're doing the sharing for wave 1, team sharing wave screening work, including OB communication and OB and infant. We're going to discuss our urine versus SBIRT barrier and our discussion with Dr. Wright. Is this where you're talking, Dr. Young?
Yeah. So I'm going to be talking, I'm going to take off my TIPQC hat and put on my Vanderbilt hat. I should actually maybe I'll have hats one time that I bring. But anyway, so in terms of screening for substance use disorder and pregnancy, I admit I thought this was going to be easy. I thought that we were going to, because we already had the 5Ps tool built into our new OB paperwork, I thought, hey, we'll just build it into the EMR. It'll be even better, and then we'll be 100%. No, that did not happen. What I realized is that both the outpatient and the inpatient are two gigantic hurdles in a big institution, or probably even in a not big institution, they're big hurdles. What we've done for outpatient, I'll focus on that first. We created an SBIRT. We created that flow chart, and then we went to the ambulatory patient care committee to ask to build the 5Ps in Epic. Even though the 5Ps was already in our paperwork, we had to get permission to build it into Epic and really had to kind of reinvent the process for that. So once we got permission from the ambulatory patient care committee, then we went to the Epic builders. And well, we know how long that takes working with that. And so finally, after months and months and months and months and months, the 5Ps was added to Epic. We educated our MAs and our RN and the RNs who do the new OB intake to ask the 5Ps questions, and we educated the providers. And then we started getting weekly data reports, and what we saw was that our numbers were bad and they weren't improving. Our numbers were constantly at about 25%. And so what we have started doing now is targeted education with pulling a list of every new OB for the week. And our nurse educator is looking at the MA or RN who did the intake, and if the 5Ps wasn't done, doing individual education. So we're hoping that that targeted education will help. The other thing that we realized is that even though the 5 Ps was built into EPIC, it was built in a way that the 5 Ps results were really impossible to see unless you were in the actual visit, in the actual pregnancy episode, which makes it hard to track. It makes it hard for our people doing the data to go back and look at it and say, oh, this was done at the new OB visit. And so we have put in a new ticket to get the 5 Ps results to import to one of our patient snapshots. We call it the STAR tracker. So that was an unexpected finding that I think we all thought that once the 5 Ps was in the episode, it would be easy to see and track, but that wasn't the case. Switching on to inpatient, and that's almost like going to be a mini PDSA cycle in itself once we're able to actually track and see, not track, we can track it, but once we can see it more easily and providers can see it more easily, and they can see that it's been done at the first OB episode, how will that improve our numbers? Looking at inpatient screening for 5 Ps plus, we had a stakeholder meeting for input on where that would be best done. Would it be best done in triage? Would it be best done by the admitting provider? Would it be best done by the RN? So stakeholders with the labor and delivery providers, the LMD nurses, the LMD management to really figure out how that would work best. We created an inpatient expert flow chart, and our goal has been to get the 5 Ps added to inpatient charting, which in our EPIC system, the outpatient and the inpatient charting is different. And so even though we added it outpatient, it's not the same inpatient. So what we have done is created an EPIC nursing admission flow, a best practice alerts so that providers will be alerted to the individual positives for the 5 Ps plus. So if someone says yes to number 1, number 2, number 3, 4, 5, and created different responses for each of those things. And once that was all created, we had to go back to the women's PCC to get permission for this. And now this is all in the hands of the EPIC build team. But then we had to go to the nursing informatics committee. There are all these surprise committees that we got to learn about. And so it is finally being built, and it's supposed to go, I think it will go live in 2 or 3 weeks, and we will roll out education to all team members and roll it out officially. So I am hoping that we will see big changes in our numbers, and that will help our statewide numbers. So thank you. We can go on to the next one. Oh, I think this is it. Oh, no, this is it.
Just go.
Anybody from UT here?
Do we have any of our UT people?
Megan is there. Megan, let me know if you're not able to unmute yourself, because I can unmute you. I'm gonna try to unmute Megan for her. I don't know if that worked or not. Megan nope. Megan, can you hear us? Says my computer won't let us talk, or let her talk. Okay. So Bonnie, she's asking if we can come back to her. She's going to try to call in from her phone.
Perfect.
Thank you, Megan.
So now we're going to talk to Dr. Trisha Wright, who is the Professor of Clinical Medicine and Department of Obstetrics and Gynecology and Reproductive Health at the University of California, San Francisco. Yep. Oh, sorry. Dr. Wright, are you on? Let's see. Sometimes we have difficulties with, I see. No. Okay, well, perfect. We'll come back to her too. So join the conversation. We want all of you to chat in the little chat box and share your thoughts with our leaders. I don't want to go to the next steps. Let's go to our chat until Megan can log in.
I hate to be the bearer of bad news, but no one has actually chatted in anything. But I guess there's a good, I mean, Jessica, I don't know if you want to pose any questions or pose to maybe those teams that are participating in wave 2, maybe what they're thinking of focusing on other than perhaps the screening, or if they maybe found a similar issue with trying to get the validated screening kind of part, hardcore into or into their process or anything like that, because we've got a lot of folks on the line. We've got over 50 people on the line, but I don't know if anybody's got any questions or posing or
Can people unmute themselves if they want to talk? I think that would be
they should be able to. I mean, I don't believe, again, if someone can't, I can unmute them from my end because I am the host, but it's my understanding that they should be able to unmute themselves. Oh, Megan's on the phone. Okay. Megan, can you chime in?
Yes, can you hear me now?
We can. Thank you, Megan.
So sorry about that. So this is our data about our substance use screening. That was our validated screening tool, or our screening over time, and our validated screening tool. And as you can see through the progression of the project, we were able to implement our validated screening tool, and we're almost at 100% every month. So we're very proud of that. And then we've definitely improved. And when we were just doing urine drug tests as our non-validated screen, we've improved our rate of overall screening. So we're very proud of that.
Megan, what were the challenges that you've had to implementing a validated screening tool?
Probably communicating to all our outpatient providers and our inpatient providers why the screening tool was important, and then having everybody do it was difficult. But I think once we educated and had that conversation a little bit on repeat, the message seemed to stick home, and now almost every patient on admission definitely has the screening tool performed.
Can you walk through what the process looks like? Like where does it happen? Who does it? Is it paper? Is it electronic?
So currently it's kind of a mix because we have different systems that are used in the outpatient setting than on the inpatient setting. And currently our outpatient providers are asking the 5 Ps questions 3 times during prenatal care. And then anytime a patient comes to triage or labor and delivery or antepartum unit, they are asked the 5 Ps questions. And then 1 time during the postpartum visit, the patients are also asked.
And who's doing the asking? Is it the nurse? Is it the clinician?
It's the nurses. And then in the outpatient setting, there is a paper format for some of the clinics. And so the patients are given that paper format while they're in the waiting room or waiting for their provider. And the providers go over that if there is a concerning response.
Did you have more pushback from nursing staff, provider staff, or everybody was on board?
I think once we I think it depends, which clinic. Some of our providers were a little more concerned about how much time this would take. And then some of the nurses were concerned about what do we do when we have a positive P. So on our inpatient side, it's probably a little more fluid because we were able in our EMR to add directions. If positive, then, for the partner screen, if positive, please perform a domestic violence screen and alert the provider. And then if a patient has past use or current use, then our nurses are able to order a urine drug test as well.
Do you have recommendations for other teams who are implementing?
Be persistent. No, I don't know. Yeah, I think this is just one of those quality improvement things that you definitely learn barriers as you go that you weren't expecting. And it is something that wasn't the most difficult thing that we've implemented, but of course, change is always hard sometimes.
Right.
I was also going to ask, I know, thank you, Megan, for sharing, and obviously Dr. Young for sharing, but looking back at the graph, there was some really great improvement from some of our other participating teams during wave 1 regarding the validated screening tool. And I didn't know if any of them were on the call today to kind of chime in. Jackson Madison saw a lot of improvement. Erlanger, again, had a big jump. And right towards the end of the project, TriStar Centennial was starting to blip up. Is there anybody on the call from any of those wave 1 teams that would like to chime in as far as what worked, what didn't work, moving forward, anything like that? And again, feel free to chat in if you are not able to unmute yourself. All the silence is a bit worrying.
What about Regional 1? Is there someone, I think I see some people from Regional 1. Can you talk about your process? I know you all developed a paper screening tool that I got to see when I visited Regional 1 a lot pre-COVID.
Someone writing on the screen that wants to be seen? Or is that me?
I say maybe you, Bonnie. I don't know. I think people can annotate.
Well, I can speak for some of Regional 1 if someone doesn't. Yes, we were able to have the 5 Ps, the paper form. We do have a in the Cerner built questionnaire. Our biggest obstacles were there were times when people wouldn't ask all the questions. Finding when you would look over 20 charts and looking over it, to see did the nurse go all the way and ask all the questions, or did it stop and then we just went on. And then for not just the screening, but continuing on when someone did admit that they had a substance use disorder, did we work on getting them help, or did we and a lot of times we didn't. It was when I would ask providers, hey, what's our barriers? Oh, I didn't know we could, kind of thing. And then working with our leaders and saying, hey, by the way, this provider didn't feel that they could. And it goes back to, well, we did do the education. We did have didactics. They were educated on it, but sometimes it's so much information that I want to say we have backsliders where they go, oh yeah, I forgot about that. Something else was more pertinent in their brain. For nursing, it was literally they don't mind doing stuff, but when we rolled out Cerner, they were told that if it had a yellow highlighted on it, then that was mandatory. If it didn't, it wasn't mandatory, which was lack of communication from our builders to our nursing staff. And sometimes this was not highlighted for them to do. So it came down to the person who was doing it, the communication, and also the communication, which we're going to be working on, is between our infant team and our maternal team. Did anybody else have any other?
So I just figured out, since I am the host, sorry, I'm usually not the host, and I think one of the little settings didn't quite get set at the beginning, but you should now be able to unmute yourself. But there was a chime in from Angie Phillips saying if I go back from Erlanger, it's been them running the reports frequently. That way they can address when a patient is still in house, which is great. And also Kristen, I'm not too sure, also from Erlanger. So they have the SBIRT and the 5 Ps and their Epic Navigator as part of the mandatory admission assessment. So that's great. But Kristen and or Angie, if you want to unmute yourself, and you can, feel free to add more now that you can, and anyone else now that can unmute themselves. I apologize for that. We're getting anyone from Centennial or Jackson Madison that would like to unmute?
We want to hear your voices.
We do. We don't want just the 3 of us. Okay, Danielle, it says it's still saying unable to unmute. Thank you, Danielle. Host has not unmuted, but I have. Okay, what if I do this? I said I asked everybody to all unmute.
Hey, it's Angie from Erlanger.
Thank you,
Yay.
Angie. Yay!
So I think the biggest, so our 2 campuses, we did a stigma education for all of our nursing staff on how we can decrease the stigma, have that awareness around it, and just realize these are questions that we have, they're hard questions, but we have to ask them. So we did that push of education out to our employees. And then also we try to run frequent reports. Like I said, that way, if they're in-house, we can catch it, even if it's postpartum, and address it.
I love that you're doing that. So does that mean you're running reports several times a week? What's that look like for you?
Angie, you're muted again. Can you unmute yourself?
Okay, I have to wait till you unmute me, and then it gives me a bubble and I can talk then.
That is so strange. Thank you, Angie. I'm gonna try to figure out why.
No worries. So I tried to run the report like Monday, Wednesday, Friday. That way, you know, you catch it on admission. Our girls are really good about it's in the Navigator. And then our Stork team with Epic built us a report for the 5 Ps. So it's really easy. I just go in, run the dates, and it flags it.
Thank you so much, Angie. And like I said, from what I can see on my end, y'all should be able to talk.
Hey, Angie, do you have any words of advice for teams who may be just starting or are having some difficulties? Any barriers, how y'all accomplished overcoming barriers?
I feel like it was very hard in the beginning, just to kind of get that education pushed out before delivery. I think once our offices got more of an awareness and education and they were on board, it didn't seem like quite a shock when these patients come in and delivered if they had a baby. So I think if you get that pre-education, that helped. And then the awareness for the staff that some of us have stigmas or there's a stigma around this. Just that education helped our nursing staff a lot. There was a lot of YouTube videos that we sent out to them weekly and they could watch them. And I think that really helped. And just kind of them being more comfortable with asking those hard questions.
Did the YouTube videos Did you have a mass amount of people who were watching the YouTube videos, or was it a few and then you had word of mouth from that?
So we do like a weekly email, and then we also have like a crew app that we use for, you know, just to get education, read your email, things like that. And so I would post the link, I would paste it in an email, and then they can open it up on their own time or when they're at work, and they can watch it that way.
And you found that you had most of the people who would watch it that way, as opposed to coming to in-person classes or something?
Oh, absolutely. Yes.
Thank you.
And then our educators did a lot of just kind of dry erase board or a bulletin board of hot topics, and they would frequently change it. And I think that was a huge help.
Were they able to go to the clinic? I don't know if you're connected to clinics as well, or is it just in hospital?
So we have 2 large campuses. Our campus downtown has the residents. So that was the residents, of course, kind of had that great education, and they were there, I think, to help the downtown. I feel like on our campus, we didn't have the residents, and we have a huge amount of community providers. So I feel like once we got everybody on board of this is the project, this is how we need to educate our patients before they even come in. Once you cross that hurdle, then it seems to get better.
Thank you.
Thank you so much for sharing on the fly, Angie. Appreciate that. Okay, so I think I'm trying to unmute, not mute, let everybody. Does anyone else want to share at this point? Because we do have.
Is there a raise the hand button?
There is. So if you actually go down to the bottom bar where your mute, your stop, your security, your participants, there is a reactions button, and you can choose a thumbs up or what looks like a clapping. If you do one of those, I can try to find you in the list and unmute you that way if you can't get to the chat, but you should all be able to chat as well.
And also, if you have any questions for our panel, for Terry, for Dr. Young, for myself, or anybody who has participated in general question, if someone wants to answer it, we would love to hear from those of you who just have general questions that you want answered. How can we help you?
And especially even if you were not part of Wave 1, but are just intrigued about what we did in Wave 1 or what we're planning in doing Wave 2 as well. And we can also, if you do have any questions for Dr. Wright, I don't think she's on. I think she was pulled away. We can also get those forwarded to her as well if you'd like to send any chat in any of those.
Can we talk about what teams are thinking about in terms of communication between OB and pediatric teams for identification of women with substance use disorder and then screening of infants?
Yes. Can we unmute Dr. Tate and she talk about what we're working on for our in Regional One Health? So I don't have to keep taking off my hat.
I'm actually already unmuted. So
Perfect.
I'm happy. So we have actually set up a task force of sorts with members from each side of the teams. So the OB and the pediatrics / neonatology team, as well as we found it was very needful to have someone on the outpatient side that could be our champion that would keep track of patients, because that usually is what happens. They're seen in the outpatient setting, it's addressed multiple times, but as they transition to the inpatient side, because we have so many providers rotating through the delivery service, it may get missed that she's one of the patients. So we've done that, as well as reached out to IT to see if there can be chart alerts put, because we share inpatient and outpatient shares in EMR, to put a chart alert so that it would notify anyone caring for the patient of that need. And so we are actually meeting twice a month just so we keep up and we review the patients. And this has worked well in other areas of the team with joint communication about patients. So we're hoping that this helps as well. I did have a question for the panel or anyone else. With being in an academic practice, there's so much turnover of team members, right? People literally taking a different call every day, but the same team. That's one of our biggest troubleshooting areas, is making sure with such high turnover, how do you keep the communication going? And I just was wondering if anyone had any pointers between residents, faculty, new nurses, nurses switching units.
You're muted, Dr. Young.
Oh, it's fun with Zoom. Something that we're doing is created in Epic. It's called a smart phrase. And so it's basically a list of all the information that OB and pediatrics thinks are critical information to know about these patients from the outpatient to inpatient setting. And so that smart phrase is getting placed in the opioid use disorder diagnosis overview of the problem list, so that the important things like dose and has the patient had any relapses, and are they hepatitis C positive, and do they have a lockbox? Have they had Narcan education? Like all that stuff is in one place, so people don't have to search through the chart for all that information. And then that information can also get pasted or put in the handoffs, that handoff document that is within Epic, so that residents and attendings all see the same information.
I can just chime in, because I've been helping Dr. Young with this as well. And one of the good things about the meetings we're having is we have nurses there as well. So it's just not providers to say, where does everybody look at for their information? What information would be helpful from your perspective? And I think, that has helped us figure out, I know from a provider standpoint, but what about from the nursing standpoint? Or, how do the residents get information? What are we missing? So it's helpful to have those meetings to just kind of see what people need.
Good. Do we have anyone else who would like to add to that? I know y'all doing some wonderful work.
Do you want to talk about what we're talking about in terms of building for communication, in terms of flags and things like that, electronic flags in Epic?
I think what you're referring to, Jessica, is the kind of what Fetal Center does.
Yeah.
Okay. And so, we have a big fetal center at Vanderbilt, and they have come up with, I'll be honest, we're kind of going to following what they're doing, but they have a way of, flagging the chart as soon as someone enters the chart to say, basically those things that you want to know about the patient, that they are, whether they are a patient in our recovery program, and just the important information there. So we're just trying to build it into our EMR to flag people and bring up, prompts so that they are aware when they enter the chart, what this patient, to learn more about the patient.
And something cool about that, that fetal care center information is that not only is in the patient's problem list, but it also flows into the delivery note and delivery summary. And so that PEDS is able to access that very easily, and they look at the delivery note and the delivery summary. So the thought there is that not only is it going to be living in a place that OB providers and nurses can see in the patient's summary, but it will also be in the delivery summary for the pediatric providers to see.
Can we discuss the urine drug testing versus expert barriers?
Yeah. Is there a particular question about that?
And no, it's just that some facilities still do routine urine drug testing, whereas other ones, best practice says that, unless there's, reason, but like our mothers who are on MAT at some facilities may get a drug test when she comes in if she admits that she has had that, if she's been on that medication. So what are our thoughts on that?
Yeah. So, well, I would be curious to know which are there teams that have implemented a validated screening tool who are also doing universal urine drug testing? So,
We are at UT.
what's been your conversation around that?
There's a lot of hesitancy among our providers to move away from urine drug tests, even though we've found that sometimes we're having false positives, and we've had to make sure that all of our positives are being sent for confirmation, because we were running into some issues with some patients who had no history but had a positive on admission. And then of course DCS was involved, but even with all that, we still have providers who are concerned that patients are not going to be forthcoming with the 5 Ps questionnaire. We've even made them a list of, what's the word I'm looking for? I guess contraindications or criteria that they can follow. Like if a patient's there for preterm labor, you can order a urine drug test, and different criteria that allow for urine drug tests, but I don't know. They just seem to be very hesitant to move away from that completely.
Yeah, I think it really requires a big culture shift, I think. And I think that hopefully the more people get comfortable with the 5 Ps, and that might be something that is able to move away from. I know some people, some institutions, they report that their pediatric team really is pushing the universal drug testing. I know that's true for one of our affiliate hospitals. And so I think that the more that we can educate people on those false positives and the false negatives, like if doing a urine drug test isn't going to pick up everything or every risk factor, and you could actually miss babies that do need to be screened by relying, just on a urine test alone. But I think it is a big culture shift to move away from that idea. And something that I think Dr. Wright mentioned, but yeah, even a lot of pediatric and NICU teams nationally are really starting to question what is the medical utility of a test, in particular a urine drug test. When is this information necessary, and when are we really just using it as being a proxy for DCS, and is that ethical? Is that really our role to play as medical providers? So I think it's really interesting. It brings up a lot of ethical dilemmas, and it's a lot of people wanting to do the right thing for both mom and baby. But how do we thread that needle? How do we make sure that we are taking good care of moms and babies and not alienating moms and keeping them from seeking care because they know they're going to get a urine drug test?
or the facilities who do it and the mom test positive, but she hasn't used, but her medications that she used to cause her to be false positive. Then they have to wait for the blood test to come back, but she already has DCS on the radar, and then follow up, and that could potentially cause years of problem. Angie Phillips says nurse scripting helps. That one on admission, you are all asking format of questions. It's a cultural change. So she agreed with that.
So could I actually chime in on the
Please.
backside of Angie's comment? And I'm wondering, again, this is me, non-clinician. Is it, or could a difference, again, you're talking culture change, we're talking about providers, and then we're talking about nursing staff. Could it possibly be also tied with our moms may be more trusting of, say, nursing level staff than provider staff? And is it like Angie said, that if it's always from the nurse, maybe in Megan, you have less resistance from the nurses than the providers? I don't know clinically what is more appropriate, what should be done, but is that a possible different way to attack the barrier in terms of which level of care providers are using the tool and kind of asking those questions?
Yeah, I do think that it makes a difference who is administering the test in terms of, well, one, how consistently it will get done, because I think that we all can agree that physicians are terrible at following protocols for the most part, and nurses are a lot better at it. And luckily for us, they're a lot better at it. And so I think that in having something done universally every single time, having it in a nursing flow makes a lot of sense. I do think in terms of getting buy-in, you need buy-in across all levels, because often the people at the table, there's nursing leadership at the table, but the other provider leadership at the table needs to be saying, like, yes, this is important, we need to do this, we need to be addressing this issue universally and in a non-stigmatizing, non-discriminating way.
I also think the way you ask the questions, if you take your bias out of it and non-accusatory, anytime that I educate our new staff members, I remind them that it's not what you say, it's how you say it to someone. And women who are using or have been abused have fear. And if you do it in a judgmental way, asking the questions, their answer is going to be no, although it may be yes, because they don't want you judging them, or they don't want to have someone call in on them. Or there have been moms who've come in and say, yes, I used today, but can I leave now so then it won't be in my urine, so then I won't get my baby taken away, instead of what can I do to get help? Those kind of things make a difference. Not what you say, it's how you say it to someone.
Yeah, it's a really good point, Connie.
And I was wondering, from the non-clinical standpoint, it would be great if you had that relationship and that rapport with the woman over her pregnancy. So maybe it's not your first visit, or her first visit, it's her second or third prenatal visit where you've built that relationship and she is a bit more trusting. Because I could even imagine if it's on admission to labor and delivery, I wouldn't think that's going to be necessarily the time she really wants to be honest and sharing, if that's the first time you've ever, been providing care for her.
Yeah, and we found that if it is their first time and they're about to go to the operating room, anesthesia will get more out of them most of the time than anyone else, because they're going to say, if I have to give you any medications that would put you to sleep, are you taking anything that might cause complications? And they're the ones who more often will get the patient to state, oh yeah, I took fentanyl or whatever, because a lot of drug screening testing do not test for everything that the people are able to obtain off of the streets.
I think that's a really good point. And particularly now, we are seeing a lot of people who say they're using heroin, but really what they're using is fentanyl. And not just fentanyl that we can test for easily, but a lot of the fentanyl products that are on the market now, or on the, on the street now, are synthetic products that sometimes don't even test positive if we have a test that is screening for fentanyl. So this idea that a urine drug test is going to catch people or, really give us the information we need is becoming increasingly not accurate as the drugs that are on the streets change and evolve. So it's another plug for validated screening tools.
So I'm going to chime in real quick. I apologize. It's just about 4 o'clock. The Narcan training workshop, as well as the Tennessee Milk Bank workshop, will be starting at 4 o'clock. If anybody needs, wants to attend, you will have to leave this Zoom. And then if you go back to the Leader Pass page underneath the workshops to the right, you will see a link to be able to join the Narcan training or the Tennessee Milk Bank. We can obviously move forward with this workshop, but just as a reminder, in case anybody wanted to go to either one of those workshops.
Well, and I think that we're scheduled to end at 4 o'clock. So definitely, I'm happy to stay and answer any questions anybody has. But thank you all for your time. Thank you for your interest. Thank you to our teams for all your hard work and dedication in this massive, massive, but very, very important project. And thank you to Terry and Bonnie, both who are really indispensable to moving all this forward.
Thank you, everyone.
Our next steps will be to join the infant team and begin our work. Have you turned in your application? So if you haven't, we would like for you to go ahead and get on top of that. Upcoming huddles is April the 13th and May the 11th. And our June learning session is to be announced. We're hoping we could be together. Don't forget our Healthy Mom, Healthy Baby new episodes each Monday on our podcast. We've had a wonderful time putting those together. We would like for you to hear them. Our patient experience, don't forget to, we would like for y'all to listen to our patient. And thank you for sharing all your hard work. We appreciate you. Don't forget our sessions are Narcan and Milk Bank. And that is all.
And I am going to stay
Thank you.
on the session in case anybody wants to stick around for a bit longer.
Yep, I'll stay.
Again, I'll probably stay till about 4:15 or so, but everyone else can fall off if they want to. And I'm just going to be starting to play. Bonnie, if you don't mind stopping and sharing your screen, I'm just going to share a little loop video that gives some highlights about tomorrow's agenda, and hope to see you all again for day 3 tomorrow.